Welcome to RSSDI TV 2020. I am Dr. Shahu Ingole and you are watching me on RSSDI TV 2020 brought to you by Wockhardt. Today, I am honored to have with me an eminent personality and senior diabetologist from Mumbai, Dr. Anil Bhoraskar sir. Dr. Anil sir is the honorary diabetologist at Raheja Hospital, Asian Heart Institute and Asia Cancer Hospital, Mumbai. Welcome to the show, sir. Sir, we all know that the burden of diabetes is increasing dramatically, and almost half of the patients are uncontrolled on currently available anti-diabetic medications. And also, the large number of patients that develop micro and macrovascular complications. So, do you think that there are any gaps in the current management of the type 2 diabetes mellitus?
See, gaps are very evident because, in spite of having the most modern treatment available, modern insulins available, new generation drugs like SGLT2 inhibitor, DP4 inhibitors, analogs, in spite of that, our average HbA1c is more than 8. Now, why is it happening? So, there has to be some problem. We don't call it problem, we call it gaps in delivering right treatment to the right patient. And these gaps are at multiple levels. First of all, the gap is between the patient and the doctor. The doctor is not able to communicate properly what exactly is scientific jargon in simple language that the patient understands. Then the patients have their own resistance to take scientifically right treatment. Patients have enormous resistance to take insulin. And there again, I say the gap is between their caretaker and them. They are not able to convince. The patients are not convinced to take diabetes seriously. They take it lightly. And even the perception of treatment or priority for diabetes is low. When somebody says that he has got a cancer, he rushes immediately for all kind of treatment. He's got a heart disease, he immediately goes and get admitted in ICU. But the moment you say you have diabetes and you are likely to develop kidney disease, he takes it lightly. Okay, I'll stop sugar, I'll not take carbohydrates. But that's a wrong attitude, and that is the biggest gap. And it is going on for years together. And in spite of all the advances in technology, in advances in therapy, in caregiving, we still don't see the success of treatment. And that is what I call a big gap between the medical world and the patients.
So, how do you think that how to bridge these gaps so that we can achieve the proper management of the diabetes?
First of all, we have to educate the educator. I talk it very confidently because I got a prize for a best educator this year. Now, educating the educator is one of the most difficult thing to do. You try to teach a 40-year senior man in practice that, look, my friend, what you have been doing all this time, you have been very successful, you have been very lucky, but this is not a right way to do it. There is a tremendous resistance. But there are some people who are very quick, particularly the younger lot. They are very quick on uptake on the modern treatment, but they try to implement it. Believe me, they try to implement it unnecessarily, more aggressively, just because they have recently read something or attended some CME. So their approach is diagonally opposite. You have to keep this together. You have to give them a rational approach. You have to tell them that, look here, don't frighten the patients, but educate them. And how do you educate them? The greatest way of educating the patient is to give them the basic mechanism of disease process, the basic defects in diabetes, and how we are going to overcome them, and how overcoming is not a big job, but it's a simple job, and this can be easily achieved by every patient. If that educator himself is educated, then he will bridge the gap very easily, and he will disseminate correct scientific information to his patient. This is the way to go about it.
Okay, sir. So by adopting this particular process, do you think that we can reduce the microvascular and macrovascular complications in the diabetes patients, sir?
100%. Microvascular complications, as the all UKPDS and other studies have shown, are completely related to control of sugar. Lower the HbA1c, lower the chances of microvascular disease. So our target of HbA1c should be less than 7, 6.5 ideal. And if you can achieve this target without doing two things, very important: weight gain and hypoglycemia. Weight gain and hypoglycemia are two integral components of treatment. When the treatment is going on a right direction, patient puts on 4 to 5 kilos of weight. Many times, actually, this weight gain is a recovery of lost weight, because the patient, when they have hyperglycemic glycosuria, they lose weight. Now, when you put a patient on insulin, they gain weight. Initially, weight gain is a restoration of lost weight, but later on, they tend to gain the weight in the abdomen, visceral fat, which is most dangerous. So, while controlling microvascular disease by creating visceral fat, we produce macrovascular disease. You understand? So, this is not desirable, because you are definitely going to overcome microvascular disease. The kidney disease, eye disease can be prevented. But the point is, while doing so, two things should not happen. One, the patient should not become hypoglycemic. Second, if at all he gets hypoglycemia, he should be immediately able to restore it or correct it or prevent it. And weight control, which is optimum, that is the crux of the treatment. So microvascular disease can be certainly prevented. We have seen from many trials. But while doing microvascular correction, you should not produce large vessel disease like coronary artery disease. And particularly Indians, we are ethnically vulnerable to coronary artery disease. We developed coronary artery disease 1 decade earlier as compared to our Caucasian counterparts. And our arteries are long, tortuous, they are multi-segmented, and many times they are not amenable to plasty. We need to bypass, and the age group is 40 and 50, not 70 and 80, as you see in Caucasians. So we have to be doubly careful while correcting microvascular disease. This gap, the big gap, can be filled up by judicious combination of good dietary practices, optimum insulin, physical exercise, and control of other comorbidities aggressively. If a patient has got HbA1c of 8 but a systolic pressure of 160, I tell my students that to chase that 160 systolic pressure, which is a bigger devil than glycosylated hemoglobin of 8. So correction of hypertension as aggressively and bring it to 130 by 80. If there is a microalbuminuria, use ACE inhibitors to prevent or reverse the process of microalbuminuria, and proper evaluation of cardiac function every year to assess the left ventricular ejection fraction and end diastolic pressure. Many diabetics have a diastolic dysfunction, and there are excellent drugs now available to reduce diastolic dysfunction. So there is a multifactorial approach. The biggest gap is don't only be myopic and look at sugar, look at lipids, look at lipoproteins, look at other risk factors, and correct all the risk factors together. Then these all gaps will be filled in.
Okay. Thank you so much, sir, for sharing your views, and thank you for us for being on this RSSDI TV show. Thank you so much.
Thank you very much for giving me an opportunity to express my views.